Hey all, welcome back to the Real Life Pharmacology podcast. I'm your host, pharmacist Eric Christensen. Thank you so much for listening today. Head on over to reallifepharmacology.com. Get your free 31-page PDF on the top 200 drugs. Great little study guide, great refresher, some of the most important things you're going to see in practice, as well as things that are going to show up on your board exams, pharmacology exams throughout your career. So go check that out. Simply an email will get you access to that. We also get you updates when we got new podcasts and other content available as well. So again, do that at reallifepharmacology.com. All right, the drug of the day today is Solifenacin. Brand name of this medication is Vesicare. And this medication is used for urology purposes, primarily used for symptoms of overactive bladder. So urinary urgency, frequency, and those type of symptoms. So it helps to reduce those sensations and those feelings. Mechanistically, how does this medication work? As a broad classification, it is considered a urinary anticholinergic medication. So as you could imagine, if you understand what anticholinergic side effects are, you're going to understand some of the side effect profile of this medication. But more specifically with Solifenacin, it's a competitive antagonist at muscarinic acetylcholine receptors. Now, the difference is maybe comparing it to some of the other older agents, such as oxybutynin. It tends to be more selective for the M3 subtype. So that M3 receptor subtype, that's more specifically or more heavily found in the bladder muscles, okay? And so that ultimately, by blocking that, reduces some of those involuntary bladder contractions, increases bladder capacity, and ultimately it's going to help in reducing that urgency and frequency. Now let's talk a little bit about that selectivity. So it may offer some advantage in minimizing central nervous system adverse effects. So again, I kind of lean on oxybutynin, brand name Ditropan. That's one of the older urinary anticholinergics, and that's not as selective for bladder tissue. So we can get more of the central nervous system adverse effects like, confusion and those type of things. Okay. So Solifenacin, again, tends to be a little bit more selective. But ultimately, that selectivity goes away as doses increase as well. Okay, so keep that in mind. It's not crazy anticholinergic in the central nervous system. It's maybe a lesser extent to some medications, but it still certainly can have some impact, and that's probably especially true in our polypharmacy patients who may have other anticholinergic medications on board as well. Okay, so pay attention. Frail elderly patients, the risk for some of those CNS adverse effects, like confusion, for example, certainly can still happen with Solifenacin. Hopefully, it's to a lesser extent than some of the older urinary anticholinergic. All right, so dosage forms. It's typically given in two doses, 5 milligrams, 10 milligrams, taken once daily. Careful in some hepatic impairment, as well as creatinine clearance less than 30. So in those patients, creatinine clearance less than 30, we may want to limit that maximum to 5 milligrams once daily. All right, let's dig into the adverse effects. I alluded to its anticholinergic activity. Probably one of the most common adverse effects are dry mouth and constipation. So usually these are considered probably more nuisance adverse effects that, patients can often work through, but I definitely have seen some pretty severe cases of dry mouth due to anticholinergic activity as well. Also, remember it can cause some vision changes. It can worsen urinary retention. So particularly if you're using this in a patient with BPH, those symptoms of retention could get worse with the use of this medication. Other things that have been reported, obviously the confusion I kind of alluded to. Again, typically not a major issue, but in the right patient on other medications, that type of thing that may worsen that, Solifenacin could add to that issue. Rarely, you may see some dizziness, some tachycardia, QT prolongation. Again, not one that's too high on my radar, but again, if you got patients on other medications, that may be something to think about there. And then, that risk for, confusion, delirium, that can occur due to the anticholinergic activity. Again, more on the probably rare side, but definitely something to be aware of. Now, I do want to do some education on prescribing cascade examples. Whenever you have anticholinergic medications on board, watch out for the addition of new medications. So, for instance, we start solifenacin, and then 1 week, 2 weeks, 3 weeks goes by. Now all of a sudden the patient's constipated. Now we're adding, a stimulant laxative like Senna or Miralax, which is an osmotic laxative. So that's a great example of the prescribing cascade where we add a medication to treat urinary frequency, and then we are adding a medication to treat the adverse effect from that urinary frequency medication. Keep in mind diuretics as well. So diuretics can increase urinary frequency, and that may prompt patients to come in to the physician's office, discuss with you their issues regarding urinary frequency and how bothersome it is, and that may prompt the new prescription of a medication that reduces frequency like solifenacin. So keep that in mind as well. Dry mouth, dry eyes. Keep in mind artificial saliva substitutes. If you see that, probably a good indication to take a peek at that medication list, making sure that they're not taking a medication like solifenacin that's causing that dry mouth. And same thing with dry eyes. That can definitely happen on account of anticholinergic adverse effects there. Other things, if you see urinary retention, if you see the addition of, tamsulosin or Flomax to help with urinary retention, it's probably a good indication you've got some anticholinergic activity going on potentially, or at least we should look at that. And then, of course, if you see new medications to treat symptoms of dementia, so your donepezil or your Namendaz, for example, that's a good indication, again, that we may be encountering the prescribing cascade, where anticholinergic medications are worsening confusion and cognition and leading to the prescription of new medications. So always those anticholinergics are great examples of the prescribing cascade. So again, I discussed the relative selectivity for the M3 receptors. So hopefully solifenacin has a little bit less CNS adverse effects like confusion. Probably so that's an advantage of this medication. And the other one that's relevant in clinical practice, I think, is once daily dosing. That's nice compared to, let's say, immediate release oxybutynin, which is, sometimes 2 or 3 times a day. Now, the downside probably of solifenacin is it does have some drug interactions, and I'm going to cover those right after the break here. If you're in the market for any pharmacist board certification study material like BCPS, ambulatory care, NAPLEX, geriatrics, BCMTMS, go check out meded101.com/store. We've helped thousands of pharmacists prepare and pass their exam. Again, all those resources, meded101.com/store. If you're a nurse, pharmacy technician, any other healthcare professional, we've got books on all sorts of different things to help you either prepare for exams or prepare for real-life practice. So go check out all those links, meded101.com/store. Support the sponsor, which goes to directly support this podcast. All right, wrapping up with drug interactions. So I alluded to a potential downside with solifenacin. It does have CYP3A4 drug interactions. So inhibitors like ketoconazole or clarithromycin, these can increase the concentrations of solifenacin, obviously increasing the risk for those adverse effects that I discussed in the first segment there. On the flip side, CYP3A4 inducers, rifampin, carbamazepine, these may lower concentrations and ultimately reduce the efficacy of this medication. The last couple of drug interactions I wanted to mention were more additive type effects. So I alluded to the anticholinergic activity. When we add other medications that have this activity as well, like a cyclobenzaprine, first-generation antihistamines like diphenhydramine. Antipsychotics can have some anticholinergic activity. Medications like amitriptyline. These are all meds that are pretty highly anticholinergic and can certainly have some additive effects when used with solifenacin. So pay attention to that. Look out for those prescribing cascade examples. The dry eyes, dry mouth, constipation, worsening confusion. These are all great examples of things that should kind of flip a switch in your head to look out for medication adverse effects when you hear of patients reporting some of those concerns. And then last but not least, with the drug interactions, I will mention QT prolongation. Again, it isn't crazy high on my radar with just solifenacin alone, but when we've got other QT prolonging agents, antiarrhythmics, amiodarone, maybe some antibiotics that can prolong the QT interval, that's an additive type effect with solifenacin. Might be something you need to watch a little bit more closely. So pay attention to that, understand your patient's history, cardiac history, and those type of things. All right, well, that's going to wrap up the podcast for today. Thank you so much for listening. Do me a huge favor. Leave a rating review on iTunes or wherever you're listening. Support the sponsor, meded101.com/store. I greatly appreciate that. All those purchases go directly to help support this podcast and keep it free and available for all to benefit from. So go take advantage of that. Look at those resources there. Of course, if you want to reach out to me, comments, suggestions, feel free, mededucation101@gmail.com. Otherwise, you can connect with me on LinkedIn as well, Eric Christensen, PharmD, BCPS, BCGP. With that, I'm going to sign off for today. Thank you so much for listening. Take care, and I hope you have a great rest of your day.